The topic for today is the challenges that we face when we treat HIV in the correction setting. This is going to relate to the Texas Department of Corrections, but I'm sure this can generalize to all of the correction settings. Most of them are set up exactly the same way. The objectives, well, to find out what challenges do we face and hopefully to come up with innovative solutions in order to overcome these challenges. And I based most of this out of the cases that I have been consulted on. Because unfortunately the back ends with me. So if any of my providers have problems with the patients, they usually get referred to me. So let's start. AB is a 36-year-old Hispanic male, and he's diagnosed with HIV and hepatitis C in 2016 when he was tested positive for morphine derivatives in a random drug check. Not too random, he was acting a little queer. So they did a drug check and found out that he was positive for it. He also was noted to have abnormal liver function tests. So that leads us to the first drug epidemic, the first challenge, which is the drug epidemic. Since it's been recognized, I think as far back as 2015, we started looking at the challenge that it poses. In fact, this was put to light back in 2014 in Scott County, Indiana. That little town in Indiana had about 5 HIV cases a year. And in 2014, they had 181 cases diagnosed. And so everybody was like, oh, what's going on? And they found that it's linked to the opioid epidemic that was sweeping the town. And most of their diagnosed patients were actually young adults. And so it highlighted that we have a problem, and we're a little late in coming to terms with it. So since then, there have been a good many number of about 15 counties, mostly in the west and in the south area, where they started picking up that we are having a little bit more HIV diagnoses that are being linked to the drug use. But the good news is, as of the 2016 statistics, we really didn't have a rapid rise in the HIV diagnosis. And the prevalence of people living with HIV has stayed pretty much stable. So that there's about 342 people living with HIV for every 100,000 people in the United States. And that's reflected also in Texas. So for every 100,000 people living in Texas, there's about 344 living with HIV. Now that gets distilled in the prison system, so that we have about 3 times the prevalence of people living with HIV for every 100,000 prisoners that we treat. Now, if you take a look at this, as you can see, the prevalence, as I said, stays about the same. Now, those yellow dots that you see there, that actually highlights the percentage of people who have HIV for each age group. As you can see in the age group between 20 to 44, that's a pretty high percentage for the people in that age group. So that even though our prevalence is staying steady, but compared to people in each age group, we have a problem in our young adults. And this is also the people that we see in prison. This is the age group of the people that are currently incarcerated as of 2016. So the most are in the 20 to 29, 30 to 39, and 40 to 49. So it's about the same, that's higher prevalence in the HIV population. So when the free world realized that we have a problem and it is linked to the drug epidemic, the answer that they came up with, or one of the answers they came up with, was establishing a syringe exchange program. This was done back in the early 90s when the AIDS epidemic was just blooming. And they said bathhouses and needles seems to be the problem. And so there was a big campaign for needle exchange program and condoms use. And so we know that these programs do work. So outside of the prison system, this is one of the fundamentals that the CDC have been giving out to counties who think that they may have an HIV and drug use epidemic. In the prison system, well, the drug use a lot of times is what got them there to begin with. So there cannot be a syringe exchange program in the prison because it's a catch-22 for the patient or the inmate. If you go ahead and did a needle exchange, you pretty much admitted that you did something you're not supposed to do. And so the most acceptable solution is actually a rehabilitation program, pretty much what's being advertised a lot on TV these days, saying that, if you have a drug problem, we will take you to rehab so that you will not have a drug problem anymore. At this stage, because it's codified in our law and statutes, this is the only response TTC can have. Okay, continuing on. So we started him, and I'm sorry for the alphabet soup of medicine, but that's Viriad or tenofovir, Epivir or 3TC, and a boosted darunavir or Persista. So he got started on a standard, and he had good tolerance. He took the medicine properly. His CD4 went up, his viral load went down, so everything looks like it's going according to plan. However, his liver enzyme, which, after it increased the first time, it went down, settled down away from the drug use. It went up 5 times upper limit of normal, which is an indication that there's a drug-induced liver injury within a couple of months of starting the medicine. So his medicines were stopped. We went through the cycle about 3 times. And each time, his liver enzymes keeps going up in a shorter and shorter period. So we started out within the 2 months, then it became 6 weeks, then it became a month. And so we even went all the way to just giving him tenofovir and Epivir, which are both renally metabolized drugs. His liver enzyme still went up. So we had to take him off medication altogether. And brings us to the second challenge that we face. Whenever they have co-infection, particularly hepatitis B and hepatitis C, makes it difficult to manage their medications. We all know that herpes virus facilitates transmission of HIV. And HIV returns the favor for making your herpes attacks a little bit more virulent and a little bit more frequent. Same is true with varicella. Now, with hepatitis B and hepatitis C, we know that the progression of liver damage is a whole lot more rapid in the setting of HIV. So that instead of encountering cirrhosis in about 20 to 30 years, which is the natural history of hepatitis C, you tend to see it more like 10 years or 15 years in the setting of HIV. Now, the last one is actually anecdotal, that for some reason, when they are co-infected, we have a hard time, and this is, I used his case, but we actually have more of a handful of patients that are co-infected. We are having a hard time dealing with their ARTs because they start exhibiting increase in their liver enzymes. And so it's something that needs to be explored further. Now, as far as innovative solution, right now what we came up with this particular patient is that we decided we're going to treat his hepatitis C first. which sounds a little counterintuitive because what you were told about hepatitis C treatment is that you gotta stabilize the HIV, make sure they're suppressed, their immune system is good. But in Expedition 2 study, and this was just recently published, they did include about 9 patients that were treated with the Mavorite drug. That's the brand name. The pangenotypic, other than the Epclusa, it's Mavorite. It's glecapavir with pibrentasvir. They make it tongue twisters. Anyway, they did have good results out of that 9 patients who were not on ARTs, but have CD4 count of 500 or higher. So they have a pretty robust immune system, and they were included in the study, and they did have pretty good results. So we're gonna try it out on this guy, since it doesn't look like we're gonna make any headways with his HIV treatment. The other thing is that you need to have a high index of suspicion for the co-infection. So if you're looking at something that kind of looks like herpes, or maybe herpes, it's incumbent upon you to go ahead and treat it. Because within 72 hours, if you do not start treatment for the herpes virus, you're really not going to make as big an impact as when you catch it as early as possible. So if it kind of smells like herpes, treat it like herpes. Okay, moving on. CD is a 65-year-old black male who was diagnosed with HIV since the very beginning. So he's been dealing with this for the last 23 years. He's variably compliant with this medication, and that led to having a multi-drug resistant genotype. So almost everything that you can see in the Stanford genotype mutation, he's got it. But we were able to achieve viral suppression with a combination of isentres, boosted Persista, and Fusion. ENF is enfubertide or Fusion. So he's one of our Fusion patients. And since he's 65 and gone through the whole gamut of it, he's got significant coronary artery disease. He underwent a 2-stent PTCA about a year ago. He's got diabetes, high blood pressure, chronic kidney disease, bipolar disorder, and COPD. So he can sweeten the soup. These are his medicines. I think there's about 17 of them the last time I counted. Take a quick look. We're going to move on. And leads us to the challenge number 3, which is something that the free world is also dealing with. Since we've gotten really, really effective medicine, our patients are getting older and older. And that's even more remarkable in a prison setting, because the things that you have available as resources for your aging population may not necessarily be available in the prison system. But we're working on it. So, they have multiple comorbidities as demonstrated by CD. They have the long-term effect of ART, and as you well know, almost all of the medicines we use for HIV will increase your lipid profile, will increase your triglycerides, will increase your LDL. We will put you at risk for cardiac problems. In the 90s, when we started these medicines, their lifespans about 2 to 5 years. So it doesn't really make much difference. But we've gotten so good. Like this guy's been around 23 years and still kicking and still giving us problems. They're more prone to medication side effects. They tend to get unsteady. When you have a lot of medicines on board, it messes up with your balance. It messes up with your blood pressure. It messes up, if your eyesight is falling, it messes up with your perceptions. And so they can have falls. And most significantly, they have decreasing renal and hepatic function. So the drugs that we put them on, we have standard doses for it, but they may not necessarily clear it as well as somebody who's in their 30s. So, as I said, this is a big problem. They're actually having international workshops, and this is the 9th year that they're having it. So this has been recognized going on 9 years now. And in Europe, they're actually estimating that 70% of their people who are living with HIV will be over the age of 50 by 2030. And that's just around the corner. The other challenge that this guy is having, like I said, I counted 17 drugs on there. Polypharmacy. And this is also a challenge for people in the free world. Whether they have HIV or not, with the aging population, majority of patients are on multiple cocktails, and that's not counting all of the vitamins and the supplements that they like to take on the side. So it's a problem in the prison system also. The biggest difference is we have an accounting in the prison system a whole lot better than in the free world. They have limited access to homeopathic drugs. They have limited access to supplements. And so you can account for most of the things that they're taking. But it's still a big problem. Now, as I mentioned before, HIV medicines are not benign medication. When we first started out HIV and AZT came around, it was actually a big debate whether people were dying from HIV or from AZT. So these medicines are very toxic medicines. AZT was originally a cancer drug that they revived and reused for the HIV epidemic because they didn't have anything. So we got better and better. So the medicines are a whole lot more tolerable. You don't need to take it 5 times a day on a timer. And you don't need to drink 2 gallons of water for each dose, just like what you need to do with Kirxibat. Okay? So the medicines are better. Problem is these are not clean drugs. These drugs tend to mess around with everybody else that's on board. So if you have ritonavir is one of the most toxic drugs that we have developed for HIV. And now we use it just as a booster. Because if you give it in the doses that actually affects the virus, you're going to be puking your guts out. You're going to be pooping like crazy. It is very GI toxic. And it is a very nasty player. It messes everybody else. So it messes with the other PIs. It messes with your cardiac drugs. It messes with your diabetes drug. It messes with everything because it interacts with your CP450 or CY450. I get confused with that enzyme. But it is the enzyme that's responsible for clearing a lot of the drugs that we put in our system. And so we found a niche for it as a booster medicine. But the moment that it's there, it will still interact with all of the other medicines that you have on board. If you remember, we do drug-drug interaction studies. So how we do it, we grab like 8 or 10 college kids, healthy, we want to make some money, swallow this pill, we're going to draw your blood, go measure it in your pee, and we will know how the pharmacokinetics of this drug work. In fact, in the studies, they specifically exclude old people and people who have other diseases going on. So all of the pharmacokinetics of the medicines that we use were tested on healthy young guys. So even for the women, we have some doubts on the kind of pharmacokinetics that it goes through because most of these were tested on guys. And it's not tested on a lot of people, 10 guys. I say, hey, this is the pharmacokinetics. And hey, this is the drug-drug interaction. Because there's not a whole lot of brave people who's actually willingly going to ingest medicines that they don't need. In fact, 2 opposing medicines in order to figure out how they work. Okay, so our solution. This is a bunch of geriatricians. There's actually 3 geriatricians from Rochester, New York, who took a look at the polypharmacy in our aging HIV population. And this is some of the solutions that they came up with. Now, this is a free world solution, but it can be applied in corrections. So brown bag reviews. You make them bring all of their medicine in a brown bag. So in the version of it in the prison system, we have what is known as KOP, or Keep on Person Medicine. So that's our brown bag, And because of the pill burden, the way that the prison works, they have a pill window, they have a lady that dispenses medicine, and initially they were doing that for all the medicines. Then they said, these medicines are cheap, they're not very dangerous. We can trust them to take it themselves. So we give the blood pressure medicine, keep on person. We give some of the heart medicine, keep on person. And we try to restrict the dangerous medicines and the very expensive medicines to the pill window lady. Because if you have a prison system with 5,000 inmates, let's just say about half of them will have medicine. That's a pill line almost 2,500 people long that you're going to be dispensing drugs to. And you have to do it twice a day. So it's a big logistic challenge. So we came up with just let them have it. Just like if they would have been outside, they can take responsibility for their medicine. But if you have an elderly person, just like this guy, the only thing that he's getting medicines at the pill window are his HIV drugs. So that's 4 drugs. He's got 17. So he's got 13 other things that he's keeping in his cell that he's responsible for dosing himself with. And if you have poor eyesight, if you are getting a little confused on which one it is, we try to we have purchasing power just like Walgreens. So we will always get the cheapest generic version of it. So sometimes your pills will be yellow, and maybe next time you get it, it's pink, because we changed contract. And so keeping a track of this in an elderly population is a challenge, whether it's inside or outside the prison. So they get annual reviews, and one of the solutions is having them bring all their KOP medicine in the annual review, make sure that they know what they're taking, how they're taking it, and detail what these things are for. And it's a good time to also review whether they actually need the medicine or not. Because sometimes you just keep renewing it, and they actually don't need it anymore. So that's one of. Now, it's incumbent for every HIV practitioner on every visit to take a quick look, EMR, on all of the medicines that they're on. Make sure that there's no drug-drug interaction on the HIV medicines that they're getting and the non-HIV medicines that they're getting. And sometimes we prescribe non-HIV medicine. The guy says, I feel nauseated with this drug. So you give them some Phenergan, or I'm having diarrhea. Always remember that if you're going to give something that's non-HIV medicine, start low and go up slow. Okay? And make sure